We will be providing a link to Dr. BOGART's chapter as well on this topic that she and Dr. Cunningham and Dr. Takata completed. I now have the pleasure of introducing our next speaker, Dr. Sheldon Fields. Dr. Fields is the founder and CEO of the SDF Group, which is a health innovation consultant company. You can find them at the sdfgroup.com, GRP for group. He has over 29 years of experience as a health educator, a health researcher, a clinician, an administrator, a consultant, health policy specialist, and an entrepreneur. And I will let Dr. Field introduce a little bit more about himself. He's going to be talking about mistrust in the time of COVID.
Good afternoon, everyone. And first I want to say greetings from the East Coast. And I really want to thank the really great colleagues at CHIP for the opportunity to be a part of your discussion this morning. I was asked to talk about the issue of medical mistrust during the time of COVID. There we go. Sorry about that. Working with some difficulties here. So you all have the objectives as outlined in your agenda. So we know what we're dealing with at this point when it comes to COVID-19. And this is the CDC's definition of COVID-19 and how it came about to be named. And you all know the pandemic is classified by a mild to severe respiratory illness that is caused by the coronavirus, aptly named. And why it's 19 is because of the year in which it was identified. But on this slide, I really want to take some time and focus on a few scientific facts. Currently, there is no fully FDA-approved vaccine to protect against COVID-19, but there are many ongoing clinical trials, and we're going to talk about that. There is no specific antiretroviral treatment recommended for COVID-19, although some are being investigated. Supportive care to relieve symptoms is the standard of care. The best way to protect yourself is to avoid being exposed to the virus that causes COVID-19. The wearing of masks and face coverings do decrease exposure. A person can be asymptomatic and still be infected with COVID-19 and still spread COVID-19. It is still not 100% clear if a person once infected can be reinfected with COVID-19, although we are getting some reports that this may be the case. So at this point also, by now, we should all be somewhat familiar with the timeline of the COVID-19 pandemic. But my point here is to highlight not only where we are currently and where we stand with the pandemic, but just how the pandemic has been shaped with the rapid increase in deaths, especially that occurred around April of this year, that now has us at over 5 million cases and over 180,000 deaths. All of this amidst the talk and the plans to reopen America, which has presently presented us with many challenges, especially in the many disproportionately affected Brown and Black communities. The United States leads and has the world's worst pandemic outbreak of COVID-19. If you look at the bottom slide, just in cases per million residents, you can see where the United States compared to other countries is way out of proportion. Even in how the pandemic in the United States, which was the epicenter out in Seattle, then flipped to places like New York City, we've had what we called a rolling pandemic with outbreaks in certain areas. And Florida is being one of them that saw a later outbreak. And I'm going to talk a little bit about that difference and what it has for medical mistrust as well. One of the things that we are also dealing with, because in addition to COVID-19, we are dealing with a pandemic of racism that is rooted in anti-Blackness and this country's refusal to reconcile its racist past. And we really need to have a discussion about what Black is and what Black ain't, because there's lots of discussion about, even with the announcement of the historic run of Kamala Harris, about just who is Black or who can be Black or who is classified as being Black. It has added to a very interesting social conversation. Now, however, in the current social upheaval and protests that are rooted in a long history of discrimination and oppression against Black people, starting from 1619 to the current time, this is most recently manifested in the multiple killings and shootings of Black people at the hands of law enforcement officers. The latest one, of course, being Jacob Blake in Kenosha, Wisconsin on August the 23rd. These shootings and killings date back many years and gave rise to the current Black Lives Matter movement. This movement has really taken on a life of its own and seeks to bring awareness to these many issues. Jacob has joined a very long list of people that we know well. Some we know well, such as Breonna Taylor, George Floyd, Rayshard Brooks, and Trayvon Martin, and others who, such as Tamir Rice, Eric Gardner, Philando Castile, Jordan Davis, Sandra Bland, Oscar Grant, Kayla Moore, that are not as well known or have slipped from our memories. But in keeping with our ancestral ways, we call their names, we call their names. Black America is fighting dual pandemics at the same time. We cannot talk about these dual pandemics and not address the issue of healthcare disparities, in which for Black people is very real and worsening in many fronts under the current pandemic. This definition of healthcare disparities by the World Health Organization is one that I particularly like. It talks about the differences in health outcomes that are closely linked to socioeconomic and environmental disadvantages, which are often driven by social conditions in which individuals live, learn, work, play, I often add, die. And most of us are familiar with the phrase when white folk catch a cold, Black folks get pneumonia. Well, in this case of COVID-19, that pneumonia turned to death amongst many African Americans. We have known from the very beginning of the COVID-19 pandemic that there was a disproportionate effect on Brown and Black communities, not only with how the uptake was, but who was presenting. And places, the slide up here, we saw very early on in places like Chicago and Maryland, the disproportionate uptake. And this was seen, this was very eerily sort of reminiscent for those of us who've been around for a long time who dealt with the HIV pandemic. There was some PTSD moments because the stigma, the fear related to COVID-19 was eerily familiar to those of us who dealt with the HIV pandemic in its early days. But states such as Louisiana, Illinois, Michigan, and North Carolina all had disproportionate outbreaks of COVID-19 amongst African Americans when you compared it to that state's share of African Americans in their population. And you see that at the bottom right slide. So again, we knew this was going on. We knew Brown and Black people were disproportionately being affected. Even in hospitalizations, we saw that there were differences early on. Non-Hispanic, American Indian, Alaskan persons were being hospitalized at a rate of 5 times greater than non-Hispanic whites. Non-Hispanic Blacks were being hospitalized at 5 times the rate as well. And Hispanic and Latinx persons were also being hospitalized at 4 times the rate of non-Hispanic whites. So why is this all so important? It is important because bias and discrimination and medical mistrust are all drivers of healthcare disparities. By what is some specific drivers of the differences that were seen in COVID-19, you see at the bottom, because one of the things that came up very early was, why was there so many differences in death rates, COVID-19, amongst Black and brown populations? Well, for one, there's an overrepresentation of Blacks in the quote unquote essential workforce. Take even just a hospital. There is a disproportionate number of brown and Black people who work in service positions in our healthcare facilities, that worked as healthcare aides, as janitors in food service, transportation, laundry. When white America got to shelter at home and deal with and have jobs that allowed them to do so, brown and Black America had to go to work. When you look at population density and where people live, the close proximity of brown and Black communities with public housing and brown and Black folks having to take public transportation to work increased their exposure to COVID-19. The issue of historic trauma, the mistrust, medical bias, and structural racism, and the issue of cultural incompetence, which I'll talk a little bit more about, also exists. The lower rates of health insurance and the lack of Medicaid expansion, especially in the Southern United States, which again, I'll talk about a little bit more, and the impact of the social determinants of health that I alluded to, that I'll come back to as well. And one other factor was seen early on to be a potential issue in the higher prevalence of underlying chronic conditions in Black populations, such as diabetes, hypertension, and obesity. So, COVID-19 and medical mistrust is also without a doubt driven by misinformation, a rapid and ongoing 24/7 news cycle, a failed federal coordinated response with a lack of clear leadership and the dismissal of scientific experts. We all watched the dismissal of Dr. Fauci and Dr. Birx in their expert leading of the task force from the White House. We all watched as our Black Surgeon General, Dr. Jerome Adams, quickly became mute in the discussion about what was going on. We all watched as an administration referred to COVID as a hoax, as something that was just going to disappear. We are still watching as political rallies are taking place without any regard for public health statutes and standards of social distancing and wearing of face coverings. And we're watching the push to open schools in the midst of a pandemic with the unproven belief that younger people are somehow immune. And we're watching colleges and universities open one week and close the next. We are watching a prioritization of our economy over the health of the individuals. We're watching the dismantling of the public health infrastructure through the CDC. One of their latest recommendations was that testing should only be available to those who are symptomatic, where we know that testing should be offered to those who have had a known positive exposure to coronavirus. So with all of this misinformation, lack of leadership, lack of listening to scientists, there is no wonder that there is an issue of medical mistrust when it comes to how are we dealing with the COVID-19 pandemic. I don't know if any of you have seen this absolute wonderful work from AMFAR, Greg Millett and his colleagues did. What they did was they had an analysis in which they talked about the risk and the vulnerabilities among Black communities in America, and came up with a way to actually follow the pandemic as it emerged in real time in Black communities. They took 677 disproportionately Black counties with Black populations greater than 13%. 91% of them were found to be in the southern United States. So state governments in the South have resisted the expansion of Medicaid component of the Affordable Care Act, thereby limiting health insurance access for many working poor in these very same Black counties. Now, what you
Dr. Field, I'm sorry to interrupt, but we're really getting close on time. I do agree it's a very powerful article. If we could wrap up so we can ask you a few questions. And
that's fine. What you see here was the fact that poverty, unemployment, uninsured, syphilis, diabetes, and heart disease were all disproportionately found to impact the issue. When it comes to the challenge, though, of intersectionality, because Black people are not monolithic, Black people are also, in addition to being Black and at risk for COVID, imagine also being Black and LGBT, Black and poor, Black and differently able, Black and dealing with many, many other issues. This is the chronic health conditions that I was talking about. And you see that there's a disproportionality amongst all things like high blood pressure, diabetes, and stroke across all ages. Dr. Blackstroke already talked about the medical mistrust and historical abuses. I want to talk about this. And she talked about this study. But what I want to draw your attention to on this slide is about historical healthcare provider bias, prejudices and uncertainty when treating minorities, and the culpability and responsibility of the nursing profession, which is the largest and most trusted component of the healthcare workforce. Being the largest and the most of the healthcare workforce, nursing has a social contract with society which obligates it to care for everyone. This is based on the ANA's Code of Nursing Ethics. However, the nursing profession is currently 80% white and 90% female. This, to me, as a Black Latin male nurse, underscores the profession's violation of this social contract. With its current racial and gender makeup, nursing does not mirror the society that it is entrusted to care for. In sense, we touch so many lives. My pushback to my mainly white and female nursing colleagues is exactly what percentage of the ongoing healthcare disparities in nursing is nursing's fault? And do we get to a nursing profession that is more diverse and able to serve society in a culturally competent manner? The social determinants of health we discussed, but this definition of healthcare equity that Dr. Camara Jones talks about, if we ever get to it, the assurance of conditions for optimal health for all people, following the principles of providing resources according to need, valuing all individuals and populations equally, recognizing and rectifying historical injustices. Telemedicine and the issues related to telemedicine. If people are asking, if we have a problem with regular healthcare, would we have a problem with our new norm of providing healthcare via telemedicine? And the answer to that question is yes. And how could we deal with this going on an ongoing basis? Here are some advantages about the use of telemedicine in terms of reducing wait times, giving more feedback, access to specialists. And here are some concerns: the physical absence of the provider, invasion of privacy, and people feeling that there's lack of issues with language and cultural competence amongst providers.
Dr. Fields, unfortunately, we're kind of over our time. I'm wondering if you are going to be able to stay for the last portion and where we can have more of a discussion and hopefully get to questions or further comments related to this particular topic.
Sure.
Yes?
Yeah, I'll stay.
All right, thank you so much. And you've given us a whole nother rich sort of menu of things to think about and chew on in terms of the very particular predicament we are now in that has been brought about by our current administration and this pandemic. We now have case presentations, role plays, which will be done within breakout groups. And Dr. Takata is going to provide instructions for these role plays. And I do really ask, these role plays, we think they'll be really rich, but we do really ask that people pay attention to these instructions because it may be just a little bit complicated. So Dr. Takata, if you could please let us know what to do before we break out into the groups.
Thank you, Dr. Hauer, and thank you, Dr. Shields, for a wonderful presentation. And I think it'll be really relevant to one of our cases. So we'll be heading off to role play cases. There'll be 2 sessions. This is one of them. So for each of the cases, the first page is the instructions. So please read this page first. If you assign a physician role, which could be nurse, trainee, attending physician, resident, or patient role, and only if you're assigned one of those roles, scroll down to read your part, and each page has a nurse script or a patient script or attending physician script. The patient part is scripted in an effort to increase authenticity of the role, so there'll be things in quotes that I would really encourage you to stick to. Well, the clinician scripts are a little bit more open-ended, so please act as if you would in your own settings. And again, please only read your part and then play as you would in your own settings. I will also additionally ask note takers to take notes in Google Docs slide presentations. This will be shared in the entire group report back session at the end of the conference, and each group will have 3 minutes. I will also have a timekeeper who will make sure that we stay on time, 7 minutes for the role play and 8 minutes for discussion to be started when the role starts. And please make sure to leave time for the discussions, because I do believe that that's going to be the most interesting and meaty part. So once you are finished role play, please go to the last page of the case, the discussion questions and some key learning points that we prepared. Okay, thank you, everyone.
Thank you. The 2 role plays that she was referring to, there's links for them posted in the chat. When you go into your breakout rooms, you will be assigned either case A or B. Just click the link for that and you will see a document will open up with everything that the Dr. Takata referred to. Groups 1 through 6, and your group number should be in your top left, will address case A. Group 7 and up will address case B. All right, we'll be breaking into these groups. As we said, just start by reading them and assigning the roles, and then if you get assigned a role, focus in on your part. Hello, everyone. Nice to see everybody again. I think it's almost a little disorienting as we get zoomed in and out of these rooms, but I hope that that was a good discussion. We'll have a second one soon, and but now I get to introduce our next speaker. Everyone can hear me? Great. So I'm happy to introduce our next speaker who's going to be talking about mistrust in the context of HIV, STIs, and hepatitis. Dr. Gifty-Maria Jane Ntim is a primary care physician who's board certified in both internal medicine and pediatrics. She joined the Department of Internal Medicine at UCLA as an assistant professor in 2016, and prior to that, she worked with federally qualified health centers in both the Antelope Valley and South Los Angeles. Dr. Ntim, hopefully, there we are.
Hi. All right. So I'm going to, in the next 15 minutes, try to, talk about mistrust in the context of HIV, hepatitis, and STD prevention. As Dr. Herrera, talked about, my background is really in primary care, but I do have experience in HIV and STD prevention in particular. And with that, I would like to just, share that I have no financial interest or relationships to disclose. I wanted to start off with a case, and this is actually a case from my past clinic. This patient came to see me when I was at APLA Health. He's a 23-year-old African-American man who presented to clinic with purulent penile discharge and dysuria. He reported having sex with both men and women. Patient was offered STI testing and treated empirically with ceftriaxone and azithromycin. However, this was patient's third visit to the clinic in an 8-month time interval, and the past 2 visits were for treatment of primary syphilis and genital herpes. And so he and I had a discussion about starting him on Truvada for pre-exposure prophylaxis against HIV. And the patient's response to me was, I don't want any experimental medication. I'm not a guinea pig. So, as, his medical provider, I want you to put your, self, in the role of medical provider and, think through what you would do. What I plan to do actually is I plan to actually share some data specific to HIV, STIs, and hepatitis, and then I'm going to close the case towards the end of my presentation. And of course, if people have any thoughts, please feel free to chime in then. So I wanted to show this slide, that basically highlights the fact that although African Americans account for about 12% of the US population, they are disproportionately burdened by HIV. Current data from the CDC suggests that about 43% of people living with HIV and AIDS are African American, and also Blacks account for a larger share of HIV deaths. In Los Angeles County, 1 in 3 men who identifies as having sex with men has HIV. So I think that this is actually really important, and I share this with my trainees all the time because I work with residents. I share this with my residents that, whenever, a patient, who falls in that demographic, meaning you're seeing, an African-American man who tells you that, they're having sex with other men, you should think about this statistic, and you should, your next question should be, if they're HIV negative, how are you staying HIV negative? I also wanted to highlight the fact that in the literature, medical mistrust amongst African Americans has actually been shown to, partly explain why there is a racial and ethnic disparity in medication adherence. And, you can see from this slide, when you look at, race and ethnicity, for Blacks, who have unsuppressed viral load, they basically carry the largest, burden, 45%. I wanted to also just share in this slide, the fact that patients who identify as Black in California are disproportionately affected by all STIs. So chlamydia, you can tell, gonorrhea, and this is, data from 2018. and then also primary and secondary syphilis, as well as, congenital syphilis rates. If you look at the ethnicity of the mother, the majority are Black. Again, just, thinking about Hep C statistics, 25% of people living in the United States with chronic Hep C infections are African Americans. African Americans also are significantly less likely to achieve sustained virologic response after Hep C treatment with direct-acting antiretrovirals compared to white patients. African Americans are twice as likely to die from Hep C compared to white patients. And, one might say, well, Hep C is actually included now in the USPSTF recommendations for screening. But, a Yukon study recently found that, mistrust in healthcare providers prevents African American men in particular from seeking routine preventative health screenings. So previous speakers, did a really good job talking about, how, we got here, what the current state of affairs are. I basically just wanted to, share that as I was, preparing for this presentation, I'm part of a Facebook group of young African-American professionals. And so I just decided to just scroll, through the page for posts of medical mistrust. And even amongst Black physicians, there were several accounts on the page of health inequities in the group, as well as, varying degrees of mistrust. And these are, Black, medical professionals. Dr. Blastone did a wonderful job this morning reviewing the impact of, structural racism and discrimination, as did Dr. Bogart. But I wanted to just, have us all just, reflect on that a little bit, that, even people who are professionals in, Black people, who are professionals in healthcare, do, themselves, question sometimes, where data is coming from, and also do talk about, how they are treated differently within healthcare. So, structural racism and discrimination, is deeply rooted in, reasons why there's mistrust in the Black community. And also, as Dr. Bogart had referred to earlier in her presentation, mistrust is actually, a coping mechanism. So something for us all to, think about as well as we think of solutions to try and address this issue. So we've also, again, in the interest of time, I'm just going to scroll through this, quickly. But, we talked about how we got here in the morning. Sharon in particular, Tuskegee, is very relevant to this talk, since it was actually, a syphilis, trial. And I will share that, in my practice, I've actually had, a lot of my African-American patients cite Tuskegee as a reason why they're skeptical of taking a medication. And in particular, lots of, patients who I talk to about, taking Truvada for HIV prevention, cite Tuskegee. So this has, long, this has a lot of ramifications, in our patients, trusting that, the science behind, medicine works and that they would benefit from it. I wanted to highlight AZT trials because I'm actually originally from Ghana, and one of the points that I wanted to make was that as a Black person, not, originally from the United States, there is still mistrust in, different, sectors of, the Black community. And as, Dr. Fields mentioned, we're not a monolith, but, I remember, being in high school and, having discussions about, the ethics of the ACT trials, which were meant to, check for, which were meant to, see if ACT was going to help with prevention of HIV from mothers to infants. And I remember, there was, these trials were being done in some African countries as well as Caribbean countries and Thailand. And there was discussion about having a control group of pregnant women who had HIV who were not going to get, AZT. And, one wonders what the ethics are of that. And, I was in high school in the late 90s, so that's not too long ago. I want to spend, just a little bit of time just talking also about, the impact of HIV, conspiracy theory, and, how it sort of ties into mistrust. So, as Dr. BOGART had mentioned, before there, several, HIV conspiracy theories, floating around. AIDS was created by the government to control the Black population. HIV was produced in a government lab. There's a cure for HIV, but it's being withheld from the poor. So in practice, I've had, patients, bring this up, and usually, my immediate, reaction is not, oh, that's wrong. I think it's really important to actually acknowledge, and, understand that these, conspiracy theories exist and also contribute to the health disparities, that particularly impact, patients, taking medication. And then actually there've been research that actually shows that it feeds into, the, lack of adherence to antiretroviral medications in particular in patients who are living with HIV. So usually I tend to, sort of, let my patients talk and listen and ask questions, and not just dismiss these conspiracy theories, because how you deal with this also impacts, how well your patients, trust you. So, to continue the case for, the 23-year-old gentleman that I talked about, so he actually left the, appointment not agreeing to start Truvada for, PrEP. But, he and I, developed, a rapport. He agreed to come back and see me for primary care. And, after, 2 more visits with me, he actually started, taking PrEP. And, my practice at APLA was in South LA. My practice currently is in Santa Clarita, and he actually followed me to Santa Clarita, and he's still adherent on, with his PrEP regimen. So, how do we move forward? As I see, I'm just going to just share, some of my thoughts. Some of, these points have actually been brought up by our previous speakers as well. But as I see it, I think that it's really important to, acknowledge, how we got here, the historical context. But it's also important to, affirm, patients, experiences of discrimination. And then also, it's important to let patients know, it's not in their heads, because, a lot of times patients have, this feeling that, well, you're not, and this is most likely in my head, or this is how you're going to tell me it's in my head. And I think it's really powerful for you to listen to your patients and let them know. From my experience, it helps with building trust that what they're feeling does happen, and it's not in their head. And then I think it's important to, practice empathy, understand where your patients are coming from. I, talk specifically about the conspiracy theory and what my approach normally is to that. I think it's important that we educate our patients and we talk about, what's fact and what's, fiction. But I think that, at the outset, if you were to, tell someone, no, you're wrong, this doesn't make any sense, it doesn't really, help with, forging trust and, also helping, especially in the, case of HIV prevention or HIV treatment, patients actually agreeing to, take medications to prevent HIV or to actually stay on their antiretroviral medications. And then, Dr. Bogart actually spent quite a bit of time also talking about motivational interviewing techniques. But I found in practice, that this actually is very helpful. Since I'm a pediatrician, I also use it a lot, with my patients who are refusing vaccines. But I found that, use of reflexive listening, trying to, understand, what is behind your patient's decision making, it's helpful. And then coming up with, a plan together, is very helpful. And then especially with regards to STIs and HIV prevention, the importance of social networks is very important. And then also community-based interventions. There are a couple of, people, as part of the panel this morning who actually, work, in this space and can speak more to it. But I found that it's, people actually, care a lot, what their friends think, and, being able to capitalize on, social networks and, intervening to dispel certain myths, is helpful. And also, educating, the community in general on why, certain treatments work, how they work, goes a long way.
Dr. Ntim, we need to wrap up and ask a question or two, but can you just make your last point?
Yeah, so my last point, which I think is really important also, is that diversity of healthcare force really matters. I think that, having, different people in healthcare is important. And just wanted to just, put a word of thanks to Dr. Herrera, and I'm ready for questions.
Okay, and Dr. LaShonda Spencer's going to ask.
Thank you, Dr. Ntim. That was wonderful. I really like that last slide with the steps. I think that's really helpful and important for providers. So the question is, your case demonstrates the importance of respecting the need for patients to tell their story and to build trust and make their decisions. With fragmented care across providers and time, what strategies can we use to let patients build trust and tell their story?
Yeah, so it's a good question. What I found actually works, just because it's really challenging sometimes when you're running behind and you have a limited amount of time to see a patient, to actually, build up, the rapport that you need so that patients actually, trust you. But what I found actually helps is taking a couple of steps. I always try to sit, and, be at eye level with my patients, when I meet them for the first time. And I also encourage my patients, to, if I'm not able to get through everything that, we're trying to get through in a visit, I encourage them actually the next time that they come to, prepare a list. And, I always, tell them I might not get through your whole list, but if you have a list with you, it's helpful just because it helps to orient both of us. I might think of, I might think that, something is important to address, like for instance, something on your lab work, but then you might actually be concerned about other things. So I encourage patients to do that, but really it's going to be lots of, follow-up visits. That's what I found, helps, especially at the beginning, if you have a patient who is a little bit, unsure of, how to proceed with, specific treatment or medical plan.
Thank you. Are there other questions for the chat? Please put them in. I just wanted to follow up, Dr. Ntim, I think that is important, as providers, that sometimes we have our own agenda of what we want to accomplish in the visit, but it's really important to respect what the patient has to say and what's on their agenda, because sometimes the two shall not meet. And in order to build the rapport and the trust with your patient, sometimes, you know, I think addressing their need and making sure that you get their top need met, and then moving on to whatever your need, particularly if, you know, you can do that and it's not life-threatening, in terms to put their priority first, because that's how you build trust with the patient. They usually will come in with a priority need for their visits.
Yes, I completely agree with you, Dr. Spencer.
And thanks to both of you for really bringing home some of those key points and that experience and wisdom from your own clinical practices. We are now moving into our next role play. The approach is the same. Dr. Takata, do you have any quick reminders you want to give to people?
Yeah. So the next role play does have more roles, so 4 clinician roles and 1 patient role, and also has 5 scenes. But I do want to encourage you to make sure you leave enough time for the discussion. So I know it might be a little bit of a whirlwind, but please make sure you have some time to debrief.
And the link is there in your chat. Welcome back, everyone. I think, I don't know if your all's experience was like ours, that we would have liked more time, but I feel like I've wanted more time for every aspect of this. So hopefully we'll be able to feel a little bit more complete as we go to the closing part of our day, because our final speaker is going to be our rapporteur and help to summarize what are the main issues that have come up, the main points from the speakers, some of the responses of the audience, and then we'll have a little bit of a chance to talk about what came up in the role plays, at least for a few of the groups. So Mr. Ace Robinson is an administrative and policy HIV advocate and public health expert. He serves as the National Minority AIDS Council as the director of the Center to End Epidemics. In addition, he co-founded the AVIO Foundation that combats violence through brain health, community education, and community engagement and education. And he serves on several boards, including the Community Advisory Board for CHIPS and for this particular training. All of the people who have spoken today have much more extensive bios, and we will share a link to their full bios so you can learn a little bit more about them. But we didn't want to take too much time away from what they had to say, telling you all about them. So, Ace.
Thank you. Thank you, everyone, for being so engaged today. This is a really long day. I know we're moving into the virtual space, and sometimes these things can be draining. So I'm really impressed by the level of attention and interaction that we've had thus far. So I'm going to go real quickly through some of the presentations, some of the takeaways. We'll talk about themes, and then the real part of this conversation is we want to get your feedback. We want to know what happened in your groups, and have some. I'll pick up some of the breakout groups to give some reports back. And then after the report back, we're going to go into a general Q&A so that we can make sure that we're answering some of those questions that we didn't get answered throughout the day, because I know there was just so much information, and we just wanted to make sure that we got an opportunity for getting direct feedback with the presenters who have spent the entire day with us. So earlier this morning, we had Dr. Blackstock, and she really drove home some salient points about healthcare being a social determinant, and looking at things like economic stability, physical environment, and looking at like the community and social context that we're all living in that impacts people's health outcomes. So when we're looking at healthcare inequities, she was very clear that inequities are based on pervasive historical lived experiences. And then this also is going to lead into like the historical medical mistrust that has been earned throughout from the medical field. It's not something that has come about from the patient's perspective, but it's come specifically from things like racism, classism, homophobia, transphobia, stigma. She also laid out not a logic model, but an illogical model of medical trust. And when you just look at the pathways of where we're going to, of how people got to the point of having poorer health outcomes, not to their own doing, just talking about like when they say the sins of the father, like all those pieces that come through from a historical context and from our today and our clinical experiences of how people are treated in the clinical setting. And then speaking directly to those historical pieces, it's almost like a day-by-day history of the experiences of people of the African diaspora within North America. It's talking about the transatlantic slave trade, all the way talking about the Black corpses in the medical establishment. What happened was segregated hospitals until forced integration due to Medicare. And then modern day experimentation. And we heard many times people speak about the United States Public Health Service syphilis study that was conducted in Tuskegee, and it's a large impact. And so when we're going through this, all these things are well documented and well felt by the community. And that leads us to the reality of people in the clinical settings today. So people of color often report that they are discriminated within the clinical settings. And then some of this stuff might be explicit and some might be implicit. So what is your communication style? Are you speaking like you're speaking to one of your friends? Or are you speaking like you're speaking to someone in a different community? Everyone has a different language. How are we going to make sure you adapt your language to meet the person in the middle? And then making sure that healthcare providers don't believe in some of those differentiated eugenics leading things related to how people who are Black might have different bodies, thicker skin, and that the experience of Black people might be different, like of higher pain tolerance, which leads to all that maternal health disparities. And then we saw directly like how your likelihood of dying from from an early cause compared to compared to the white population is higher, and it just keeps getting worse over time. So your proximity to racism is just going to grow and it's going to aggregate. And conspiracy theories are related to treatment-related beliefs. There is no distance between the two. Then we heard from Dr. Laura BOGART. She spoke directly about mistrust and like how mistrust is the form of resilience. So we hear that from Dr. Blackstone and Dr. BOGART saying like, if we are going to be realistic, we have to accept the fact that medical mistrust is a way for people to survive. So it's like we have if your response to medical mistrust is going to be less prevention utilization, it might have worse health outcomes. But your ring goal of why did that even come up is that you don't trust the systems that are there to keep you alive. And so it's up to the providers to build those bridges, because you have to undo, remember, the sins of the father, you have to undo those issues. And then speaking about the expansiveness of medical mistrust, we're talking about like healthcare systems, providers, pharmaceutical treatment, and then looking upstream, because any of us who have ever done any work in public health, we always look at what is our core causes, what is our root causes. And we're looking at that unethical and homicidal behavior of researchers. And we cannot say like that is going to be no impact on people today, because that does not make sense. That like this happened to your father, this happened to your grandmother, but then somehow you're going to suddenly trust the medical environment. So and it's a logical response. So it's talking about resilience and survival. When we're talking about Black Lives Matter, all the work that Dr. Fields referred to, we're talking about how are people going to survive in today's day and age. And looking at COVID-19 and HIV, it's the same but different. It's like, all right, so we're looking at is HIV man-made, is COVID-19 man-made? Is there a cure? Is there for HIV? Do we already have treatment for COVID-19, but the government's not giving it out? And so it's all about those things, like how it doesn't matter what the entity is, you're going to keep having these same issues. And what are we going to do? We look at some things like community-based peer navigation. We have to look at how to train providers to better serve their community. And we have some great examples of what to do, making eye contact. How are you going to adjust your body language? And this is the one piece that came up during the Q&A. validating feelings and experiences of the patients. If you're not validating their experiences, then you're not going to have that level of kinship. You're not going to mesh. You're not going to do all that active listening that we're all taught to do, but you have to put that into practice. And always ask for permission to share information, make sure that the patient knows they're in control and that you're working for them. And then at the healthcare organizational level, we'll speak a little bit about this later, talking about diversifying the healthcare workforce. Look at your healthcare workforce. Is it diverse from leadership all the way to the frontline staff? If it's not, then you already know like the lack of community trust from the people sitting in the patient area is going to go down. And then also make sure that you are empowering those patients. You can talk about civic engagement. You can talk about all the pieces to make sure those individuals are in control of their lives. Following up, we had Dr. Fields. He spoke greatly, a great presentation about what COVID-19 is doing in our community. And looking at the slow and non-existent response, especially in the politically conservative areas, and really laying into again, there is no difference between historical and systemic racism as it plays out in COVID-19. We talk about slavery, segregation, mass incarceration, the experiences of people of the African diaspora in this continent. You cannot overlook those when you're trying to address those dual pandemics, as Dr. Fields said, of racism and COVID-19. And data doesn't lie. Like, our data is very clear. So when COVID-19 began, we were all looking at it and we go, oh, well, first we thought it was going to be underlying conditions. And Dr. Fields pointed to what Greg Millett was saying, that we have to be realistic, that it is not about the underlying conditions. It was about your proximity to racism. The underlying conditions was not a predictor for COVID progression. And myths and misconceptions lead to medical mistrust. We had mixed messaging from political leaders and a lack of consistent messaging. And looking at holistic care, Black people are not a monolith. We cannot say that enough times, that we have to make sure that you're understanding who that person is and how are you going to work with that individual differently than the last Black patient that you were working with. And speaking a little bit around healthcare disparities, we have to address knowledge, attitudes, and behaviors of clinicians and of patients, and address those biases and prejudices directly. And when we're looking at privacy and looking at the telemedicine world, we're looking at like some of the pieces that Dr. Fields was alluding to near the end, that we have to make sure that we're able to adapt the work that we're doing to the clinical space that we're in today. And equitable engagement is so important. Like, we have to be understanding like how we're going to engage individuals through Black CBOs, Black churches, Greek organizations, professional organizations, using all the tools that are available to make sure we're being culturally responsive, because you cannot say everyone in the clinic is going to be a one-stop shop if your clinic is not already where it needs to be on equity. Make sure that you're doing the work outside to make sure you're getting there. And finally, Dr. Ntim has spoke directly about how are we going to look at optimal care, learning about community behavior, and and then if we're not doing that work, we're going to have worse health outcomes. The data does not lie. We've been seeing this all day long. The knee bone is connected to the leg bone. We know full well that these issues are just going to exacerbate. When we're saying that people are not trusting the medical system, they come late to care, you're going to have worse outcomes, and then we're still going in that same cycle of how are we going to get this work done. She spoke a lot about the trust factor. We have to look at our routine health screenings due to medical mistrust, and make sure that our coping mechanism of sustained survival is not based on racial discrimination. So you have to understand that mistrust is a logical piece, just like Dr. BOGART was saying, that mistrust is logical, and you have to undo the damage that is done to a community in order to get anywhere. History repeats itself. We speak again about Henrietta Lacks' experimentation on slaves. And remember the US Public Health Service syphilis study that ended in 1972. That's less than 50 years ago. So that is well in the range of my parents, well in the range of a lot of the patients that you're utilizing, that they know this is to be true in so many experiences. So how do we move forward? We're going to acknowledge historical context, practice empathy, motivational interviewing, social networks, and diversity, and utilizing the diversity of our healthcare force to really take this work forward. So that's a lot of information from today. And really, I just want to drive home, like, what are our themes? What are our take-home messages? The first take home is, like history matters. And you cannot look at history, you cannot compartmentalize history of what has happened to individuals into the response to the healthcare field today and response to the research field today. And then turning that mirror on ourselves, like what are we going to do when you are sitting in the exam room with your client and with your patient, and making sure that you're giving them the care that they need. So are you doing active listening? Are you validating their beliefs and experiences? Are you trusting your patients with the best medical information while you're giving it in a culturally responsive manner? So we know that we have to adjust what we do and how we care for individuals based on their own experiences. And then we're going to work that into how we're going to look at our clinical workforce. Because if everyone of your patient, if the majority of your patient area is Black, so we know 50% of people living with HIV in LA County are Black, but you only have 1 or 2 Black people on staff of a staff of 30, you know you have a problem. You need to work with your administrators to really make sure that your staff reflects the diversity of the waiting room. So now I'm going to pause there because that's a lot of me talking towards you. But what I really want to do is make sure that we're getting some information back. So remember, we were all in different breakouts throughout the day. And what I'm going to do is I'm going to call on a few of the breakouts, either the facilitators who are in there, or if someone wants to speak to some of the take-homes that came from those debriefs. Just so people can get ready, I'm just going to choose 2, 3, 6, and 8. So if you were in 2, 3, 6, or 8, I really want to hear what you have to say about your experiences today and any take-homes that you're going to go with. And then after that, we're going to move into a simple Q&A to make sure that we're giving an opportunity for everyone to ask the wonderful presenters today some burning questions. So beginning with breakout group 2, I don't know who you are, so Dami might have to call you out. But if someone from breakout group 2 can share with me some of the take-home messages that they want to go with, and we'll keep it short so that we can make sure that we're giving some time for those burning questions. Dami, can you name the facilitator from breakout room 2?
Dr. Khan?
Oh, hi, this is Alina.
Okay.
I did help facilitate. Some themes that came up in our group were just the complexity. Oh, here we go. Of navigating when you have incomplete information, and then what are those barriers to get that information, right? And if we think of mistrust as being that layer in between, all of the empathetic statements that we can do, all the right things, how do we keep going even though there's that sense of unsettledness? And I we didn't discuss this explicitly, but I, suggest that whatever we need to do to stay grounded in remembering the other side's humanity, and at the same time imagining, we started coming up with some reasons as to why the patient might not have real pain. We need to be on the other side too of remembering all the reasons, all the reasons that they could have the worst pain of their lives and be the most stoic. I think we have to be open to both sides.
Wonderful. Thank you. From breakout group 3.
Yes, hi everyone. My name is Afifa. I help facilitate group number 3. Just some general overarching theme that we were able to discuss through the first case and second case is just this paying attention to the provider's tone and willingness to listen and addressing concerns was really key to that communication piece that we all, know can contribute to all of the outcomes that were mentioned throughout the conference. And, you know, from the clinician's perspective, you know, trying to be thorough and empathetic as possible, despite, you know, some patients who provide limited responses. It can be frustrating as well. And, you know, somebody mentioned that not everybody expresses pain the same way. I thought that was really profound. So.
Thank you. I think that communicating appropriately with the patients and understanding that they might be saying the same thing as someone else ultimately, but they're going to express it differently. Great. Group 6. Tommy, if you could unmute their line.
It doesn't have the facilitator's name on it.
Oh, who is in group 6? Oh, that's Dr. Bogart.
Yeah, was that? I didn't know if we were 6 or not. Sorry. So we had a couple note takers for group 6. I don't know if those.
You know, I can say something. I thought it was great. I loved the. Can you hear me? Okay.
Yes.
Yes.
You know, just I guess here are notes too. What were some of the things that were effective? Empathetic, asked about the healthcare plan, tried to fill me out in a good way. Provider did say multiple times that I hear you, which helped me feel as if my voice was being heard. We talked about a little bit about a sense of understanding that translating medical information into layman's terms can be difficult to explain. For me, as you know, I work in medicine. I'm a physician. I've done it for a long time. I do help with communications at Kaiser. You know, I was really just blown away at how much a lot of the things that we teach are, you know, open-ended questions, the empathy, asking them how they feel, checking in if things sound okay to them, making sure they agree with the plan. And then also I was struck just on a personal level about the culture of medicine and the culture of medical training. The culture of medicine has always, I'm hoping, is improving. I trained a long time ago, but it is a very, a structure that is one of hierarchy and power, especially within itself. And sometimes that aloofness and arrogance is just so off-putting when it's directed at a patient. I don't know if people can turn it off, but it was something that I struck, and it's not necessarily something that came out in the group, but when you talk about the training setting where you're training these, you know, future healthcare communicators and providers, you have to realize that how you train them and the culture you train them in will filter into how they provide care.
Great, thank you for that feedback. I was told that group 9's message turn went away, so we're going to go to group 4. Who's the facilitator group 4 or one of our day's participants?
I was hoping that maybe Andrew or Natalie could speak up from group 4.
Great, thank you. Andrew or Natalie? Are you off mute?
These things are so, come on. What about Dr. Milner or Carl?
I'm here.
Great.
I was all locked up on my computer. You know, I think I played a very, what was perceived as a belligerent patient, just giving one-word answers. But I think one of the things, the real takeaways for me was kind of the ways in which the foundation was set by the way the case was presented initially to the trainee could lead to some preconceived notions about how a patient is going to respond, and then might actually shut that trainee down from trying to pursue things in a more open-ended and motivational interviewing style. I don't know if anybody else has other things to add.
Can you say a little bit more about the motivational interviewing style that would be beneficial?
Well, for one, there was no effort at rapport building, you know, and that there was just kind of coming in and doing a series of closed-ended questions. You know, so I think taking some time to think about, and that actually came up a little bit in some of the follow-up interviews where I don't remember if it was the nurse or another clinician who was like, well, this person might be a little sheepish about speaking openly. They're concerned because they're in prison and they're now here in a medical setting, so they might not feel comfortable, you know, things along those lines. If those conversations happened at the beginning, before the trainee came in to see me, it might have created a more open relationship.
Great, thank you. So now I want to make sure we give some time for Q&A, because we have, I think all the presenters are available. If they could turn their cameras on, and then we'll go through some of the questions. I'll read just some feedback, and then we'll, if Dami can, I think.
I'll stop this sharing, sorry.
Yeah, could read some of the questions that came throughout the day that we didn't have time for. The most recent comment was, the framing and the language around the United States Public Health Service study in Tuskegee. I think when some of the utilization of the term Tuskegee study puts the onus on a historical Black university, but in ways that negates and reduces the role of the U.S. federal government and the abuses towards African Americans, and as Dr. Blackstock said, towards the Guatemalan individuals. So I don't have the list of questions from earlier. Dami, can you read off some of those questions? So now we're pulling it up, Dr. Fields, I know you, if you want to summarize some of the end of your presentation, I know we ran out of time with yours. Is there some takeaways that you wanted to make sure that we understand with that dual pandemic, as you say, between COVID-19 and racism?
Can you hear me?
Yes.
Yes.
Okay. So one of the things that I wanted to talk very briefly about, when we talk about medical misuse in the context of the COVID-19 treatment and vaccine clinical trials, that there is a lot of historic under-enrollment in clinical trials for Black people in general. Currently, there's only 10% of those who are enrolled that are Black. And medical mistrust is a huge reason why people are still reluctant to enroll. However, we absolutely, as clinicians, particularly brown and Black clinicians, must have honest conversations, acknowledge the historic atrocities, talk about the trauma it created, and lay a pathway of moving forward, because we absolutely must have brown and Black people enrolled in these trials. If they do find a successful treatment or a successful vaccine, we must have the data that supports its efficacy in populations that are most disproportionately impacted, and those are our communities. Mm. So that was one of the points I really wanted to make sure I got in. And the last thing was about the scale up of COVID-19 testing in Black communities and scaling up contact tracing, you know, using Black professionals in Black communities, in Black settings, is really important if we're going to talk about opening up and sending people back to school. We have to have a solid testing base in which to do so. And we have to be listening to the experts. And we have to deal with the fact that there's a lot of misinformation and people are getting a lot of unfortunate misguidance. So thank you for that opportunity, Ace. I appreciate it.
For Dr. Bogart or Dr. Blackstone, can you speak about what some of the most important next steps are? So we had this day, we had a great day, we got all this information, and you know, some people might have some power with administrators, some people might be just coming out of school, some people are actually in school right now. What are the next steps? Dr. Blackstone, you're on mute.
Yeah. Oh, and it's Blackstock. Although I feel like
sorry.
I feel Blackstone or whatever. That's like the most common malapropism or whatever for my name, Blackstock. Yeah. No. So much has been shared, and I think. Again, this is going to be work at different levels. And I think some of the work that's been talked about in terms of provider level interventions around being patient-centered, motivational interviewing, you know, showing empathy, all of that is really important. I do think like the culture of medicine needs to change and has been operating in this way for so long. I think someone had mentioned just the hierarchical nature of medicine. So there are many sort of aspects of the culture of medicine that reinforce the mistrust that communities are experiencing. And so I do think that there really needs, I think I had mentioned in the comments section, just work around health equity and racial equity in particular, that healthcare and public health organizations really need to start taking a lead on this work. So when I was at the New York City Health Department, where I led the Bureau of HIV for the last 2.5 years, we worked with Race Forward, which is a racial equity organization, to figure out, for instance, how do we use racial equity assessment tools in developing our programs and thinking about how we engage with the community. And it just allows you to ask questions about like, who needs to be at the table, and not just at the table, but whose voice needs to be heard and amplified, and just sort of just slowing things down so we can figure out how do we make sure that everyone is represented at the table. So just to say that I think leadership in medical organizations, clinical organizations, really need to take racial equity and prioritize it. And that means like doing things very differently. But I just want to say racial equity assessment tools can be a helpful addition to a toolkit when we're thinking about how do we work to sort of enhance trust between community and providers.
So important. Dr. Bogart, so for an individual who's, let's say, one of the trainees or one of the budding new clinicians, what should they do on Monday when they go back to their clinic?
Oh, great question. I mean, I think a lot of what's been said is so important in terms of calling for change in one's own healthcare organization and looking around and taking stock. I think it's also important that a lot of the things we talked about today should be disseminated, should be shared, you know, taking our slides and giving it to colleagues or giving talks in your own healthcare organization about these issues. Be really important for peers to hear from peers about these strategies. Even if people think, oh, I've heard about motivational interviewing, it's about, well, how do we apply this to mistrust and how do we actually use it and practice using it?
Great, thank you. I have another question for Dr. Fields, if you're still online. Dr. Fields, are you there?
We might have lost him.
No, I'm still here.
Okay, great. The question was, what are your thoughts about when the COVID-19 vaccine comes available in the U.S.? How will the Black mistrust in the medical system affect the numbers of those who will get the vaccine? And if the low vaccinations will only increase the number of deaths in the population? So really we want a solution focus, like what should we do? What should we do to really address the coming of a vaccine with the reality of racism and medical mistrust?
So we're going to have to make some priorities. We're going to have to prioritize our healthcare workforce because those people are on the front line still. We're going to have to prioritize anybody who falls into that essential worker category, which in certain areas is disproportionately brown and Black people, working people. And then we're going to have to prioritize those other groups that are disproportionately impacted first. And then we're going to have to figure out a way of increasing insurance and making sure that people have access to it without increased costs. Because we're also not talking, 30, 40 million people lost their jobs. Well, the fact that we tie health insurance to people's jobs, you don't hear the fact that 30, 40 million people also lost their health insurance.
Yeah.
This is Dr. Blackstock. Guys, I just wanted to also add, I think Dr. Bogart or someone had mentioned that so sometimes people may have like distrust in the healthcare system, but they may have trust with their individual provider. And so I think as a vaccine is being worked on, we still have like some amount of time. I would actually invite providers who are in the audience to like just begin talking with your patients to really understand what their thoughts are around the vaccine, and there may be some information gaps that you might be able to fill or concerns that you might be able to address. Obviously, it's still very early on, but I think if we have like potentially these ongoing conversations with our patients and are able to answer their questions, I think we might be in a better position. So really sort of harnessing the trust that might exist already within that therapeutic alliance, and thinking about how that can be helpful to like maybe increasing patients' trust in a vaccination.
Thank you. Dr. Ntim, are you online? Okay, moving on. Dr. Bogart, so when we're looking at like how we're going to really be culturally responsive to the needs of the patients, and understanding, just like Dr. Fields was saying, that individuals are not a model, like the Black community is not a monolith. What are some of the take-homes that you would give to your colleagues who are also not from the African diaspora to really make sure they're being culturally responsive and really being, I would say, looking in the mirror and understanding that they might be the ones who have a problem and not the patient?
Great question. I mean, the first thing I would say is listen and engage with communities and don't impose your point of view. You'll find out what's going on, what are people thinking, and what do they want to talk about? What do people want to talk about? As a researcher, that's my primary thing, is that if I'm working with communities, I find out what the needs and priorities are, and we do the research that people say is needed and people want. So from the researcher point of view, also never going in and saying, this is the study I want to do, or we need to do this. And partly this provider training is about a lot of people coming and saying, this is what we need right now. So just listening empathetically, hearing what other people need, and not imposing anything.
Great. Dr. Fields?
Ace, you know what? If we're not being very intentional with our steps to mitigate some of what we know is the problem, and the lack of diversity within the healthcare workforce is a problem. Okay. That's not being intentionally addressed. I put a comment in the chat box, and I want to come back to my comment because I am a nurse. I know I am not the angelic Florence Nightingale image of a nurse that most people have, but I've been a nurse for 30 years. And I am sorry, nursing is still entirely too white, and it is still entirely too female dominated. In the last 10 years, there was a 1% increase in the number of registered nurses that are Black. That tells me that nursing schools are not admitting Black students, and nursing schools are not graduating Black students. If you're not being intentional about solving it, then nursing is being very intentional about being part of the problem. And as the largest segment of the healthcare workforce, I want to have this discussion, and it's not being had.
Yeah. I think that the HIV workforce from all aspects, we have to make sure that the pipeline exists and ensuring that we're like, do high school students, are they thinking, oh, like what does it mean to be a nurse? What does it mean to be a physician? What does it mean to be a social worker? And not being surprised when down the road, there's none of these things exist. And we're looking at, you know, the US. So, you know, like maybe you know off the top of your head, I know like such a high percentage of Black physicians come from the HBCUs. I don't know if that's the same for the nursing school. Like, is it mostly, no? Okay.
No.
Okay.
No. There's only one HBCU that actually has a PhD program in nursing, and that's Hampton.
Hampton, okay. So I think when we're talking about how we're going to really address some of these cultural issues, and there was a comment brought up during a presentation speaking about Planned Parenthood and Margaret Sanders and, like, you know, performing abortions and racial discrimination, how that really landed in the Black community to say, oh, you're going to have increased and sometimes mandatory utilization of contraception, and how is that looking at, like, the ideas that actually this is a secret plan for genocide. So when we're looking at how we are going to utilize cancel culture with updated information, and then making sure that we're giving people information that's for their best interest around their sexual and reproductive health. What are some of the things that we can do with our own philosophy of addressing racial inequity to access to healthcare that we should be imparting to our community and especially to our colleagues? Oh, great. Dr. Bogart, you put your hand up.
I didn't. Sorry. I wasn't sure exactly what the question was asking.
So when we're looking at what has happened in the past with medical mistrust, and where we had extreme examples of involuntary oral contraception tied to your public benefits, and how that is looked at as a way of almost immediate genocide of a population, reducing the birth rate of the Black African American community. What are some of the steps and strategies that we can use to build trust when these types of experiences have been essentially in our modern history?
Yeah, and that's a good question, a very tough one, because it's like what I talked about with conspiracy beliefs, that, you know, sometimes things are true and sometimes the really extreme things are true, and we have to acknowledge them and talk about them openly. So I would just go back to that and saying we can't pretend these things didn't happen, and we can't pretend that isn't a reason for mistrust. And so I would just go back to the same strategies of, as a society, we have to be open about this. We have to have conversations and dialogue. That these things happened, but at the same time, there are effective medications. There are things that exist that can help people, and just getting the word out about that too.
Great. I was told Dr. Ntim's phone is now working. We'll get one final question, and we'll then give 30-second wrap-ups, because we want to make sure we're being mindful of time. So Dr. Ntim, are you there?
Yes, I am.
Great. So your case demonstrates the importance of respecting the needs for patients to tell their story and to build trust and make their decisions. With fragmented care across providers and time, what strategies can we use to let patients build trust and tell their story?
So, you know, I actually think that empowering patients is important. And so we need to work on empowering, you know, patients so that, you know, they know how to, you know, advocate for themselves. I think that, you know, this is where, you know, social networks and community-based interventions and groups, you know, can come in really handy. But I also think that, you know, whenever I see patients, I can speak for myself in terms of my practice, I, you know, talk to patients about, you know, their role in our relationship. and, how it's important is a two-way street. And so while I might have, the medical, background, it's really not you do what I say, it's, what makes sense for you. And in order to do that, I need to understand you. I need to understand what works for you, what doesn't work for you. So I think that, on the provider end, just being aware of that and inviting patients to be partners in their well-being is important. But I also think, just, with forums like this, teaching patients, how to, better advocate for themselves is important.
Thank you. So starting with you, we'll just do final, also please keep it short, 20, 30-second wrap up, like what's the take home message that you want to share with our 130 so participants today. Dr. Ntim, you first.
So I actually think, my last point, I think that representation matters. And I think that it's important to work, on, developing, having, more numbers, be it nurses, be it, physicians, we need, more Black and brown people in the workforce. So that's what I would, say would be one of, my call to action.
Thank you. Dr. Fields?
So the last thing I will say is about, again, being intentional with our actions going forward. All of us have a stake in this. And oftentimes people think that they don't have a big enough voice or they cannot make change. You can make change from wherever you are. And if you are not having conversations that make you uncomfortable, then you're not having the right conversations and you're actually part of the problem, not the solution.
Thank you. Dr. BOGART?
I think these points have been excellent and I completely agree. I don't have much more to add, but thank you.
All right, thank you. Dr. Blackstock?
Yes, okay, so yes, also agree, lots of great points so far. I think the reality is we're probably never going to have enough Black and brown healthcare providers to address this. And I think it's definitely one approach. I mean, I really think we need to recognize that it's not just the historic, but has been said, sort of current realities that people are experiencing that is causing this this mistrust. And so I really do think in many ways if these larger systemic issues are not properly addressed, we will still continue to have medical mistrust impacting people's ability to engage with the medical system. And so that's why I speak to how to sort of shift organizations to become more equitable and more inclusive. And we need to sort of shift also the culture of medicine in that way as well. I would also just say just one-on-one, just the idea of shared decision-making, I think is really important. And I feel like, I'm sure people have spoken to it over the course of the afternoon, but really just making sure that we're engaging with our patients and our clients and really understanding and ensuring they understand sort of what their options are, what the risks and benefits are, what the alternatives are, and really understanding what their values and their preferences are, and then working together to come to a decision together. So I think that is most important. And I do think in many ways, because people can have increased trust in their provider despite sort of larger systems level mistrust, that we do have an in and to really cultivate that therapeutic alliance with the patient.
So once again, I want to thank each one of you for giving so much of your time to prepare for this, to be a part of this process. This was a great day. So we'll wrap it up with Dr. Harara, and everyone enjoy the rest of your day. Thank you so much.
Thank you. Thank you to all of our speakers, to our tremendous panelists, and to our participants, because your active questions and participation in the role play, of course, was very key to this. I just have a few things to say in terms of wrapping up. A number of people have asked us about whether resources will be shared, and the answer is yes. We will share the slides of the speakers who've agreed to share those. We do have portions of today were recorded, and we will eventually have links to those on our website. There is a summary of Dr. Bogart and Dr. Takata and Dr. Cunningham's book chapter that we will share. I think those are the main things. Oh, we also have put together actually a really fabulous reading list of materials on this topic. We actually didn't share it yet because it was too long and we wanted to narrow it down, but we will try to share a short and a long version of that reading list because there really is some excellent work out there that we would encourage people who want to know more to look at. So just in terms of closing up, I have a couple other housekeeping things. Please do complete your evaluation. It's of course required for those who are doing CME, but even if you're not earning CME, the evaluation is helpful for us. The feedback is helpful for us and everyone who presented today. So please do that as soon as possible. For people who want to get CME credits, it needs to be completed within 3 weeks. And the link should be in your registration email. However, we believe that the CME office will also send a follow-up link to the survey that you need to complete. I want to give thank yous to everybody on our planning committee. We had a tremendous planning committee of scholars, providers, community members, patient navigators, a wide diversity of people who were part of planning for this group. I think Dummy's going to share a slide with their names in a moment, but I can't thank you enough. This is a huge amount of planning that goes into thinking and putting all of this together. I heard Dr. Fields talk a number of times about being intentional, and there's a great a tremendous amount of intentionalism that goes into all of this work. Doesn't mean we always get it right, but it's certainly there and a whole lot of hard work. I also want to thank the CME office who provided the CME, got the word out about this event, provided a great deal of support. Our technical assistance team, who's tried to help get everything run as smoothly as possible in this virtual environment. Thank you for the people from that team who I know is PSAVE, but I'm sure you have an official name that I don't have in front of me. I want to thank the CHIPS leadership for supporting these efforts. I need to thank and also the Dean's Office who provided financial support for this particular training. So thank you to everyone. I would just like to close with, there's a quote I wanted to close with, and this is from a blog that was recently in Health Affairs. It's called Making Anti-Racism a Core Value in Academic Medicine, and it kind of speaks back to the last issues about training. This blog by Dr. Olaiwola and several others, I would definitely recommend it to everyone. It's on our reference list, but specifically they say, and I'll just share this as a close, academic health centers are often regarded as sources of truth and leadership in the communities they serve. However, that status cannot be assumed. It must be earned and renewed. And so this speaks to this whole process of trust being something that's earned and not necessarily a one-time thing that we can expect patients to give over, but is earned and re-earned over time. And so they go on to say, we call on all involved in healthcare to translate their anti-racist affirmations into their core values, which would then inspire actions that improve education, engagement, policies, practices, and funding within their organizations and among the lives of those they serve. So with that, I thank you. I hope you have a great Saturday and that Monday or tomorrow you start putting into practice some of what you learned today. Thank you.